So good morning, good to see everybody here. Lots of familiar faces out there in the audience, so I appreciate your support. I'm very excited to be here at TMA this year. But my name is James Sheets, and we're going to talk this morning a little bit about immunoglobulin therapy, or IVIg, or Subcutaneous, and really how that can be individualized for the individual patient and tailored to meet your specific needs. Before I get started, I'd like to start with a survey. So how many people in the room have had IVIg before? Okay, that's a good group here. All right. So out of those that have had IVIg, who gets it in a infusion suite? So in a doctor's office or the hospital. Okay. And who gets it in the home? Okay, so the home has it today. Usually it's about 50-50. So most of the time when I ask that question, about half the people get it in the home and half the people get it in another site of care, like the hospital or physician's office. I think it's important that all the sites of care are available, because in the end, what's right for one is not right for someone else, which is why I really want to talk about individualizing, and that includes starting with the site of care. How about subcutaneous Ig? Has anyone had subQ Ig?
I'm interested in it.
And we're going to talk a lot about it. So we'll talk a little bit about Subcutaneous Ig, and it's really an emergent therapy, and something I think we'll see a lot more of in the future. Okay, before we get started, let me share a little bit about myself, just to give you some perspective of who I am and how I came to be here. So I am a pharmacist. I'm a clinical pharmacist. I graduated in 2000 and almost immediately went into home infusion. I had a year that I was in retail pharmacy and really felt like I wanted to be somewhere where I could use all the skills I had just learned with individual patients, and home infusion is the right place for that. Doctors really rely on the pharmacy and the nursing to work together to be their eyes and ears for the patient while they're in the home. And so I did that for a few years and really felt it fit me well. And so I started my first home infusion company in 2005. And that company did a little bit of everything. And so we did a lot of IV antibiotics and parenteral nutrition. But it was also my first time to start working with autoimmune patients and infusion IVIg. And we had quite a few patients at that time, working with some neurologists in the area. And so I quickly realized that it was a therapy I needed to know a lot about, that it was different, and you really need to be on your game to make sure patients tolerate it and do well, give them the best chance of having the best possible outcome. So a few years ago, it's been now since 2013, so almost 5 years since I started CSI Pharmacy. So I'm a co-founder and the CEO for CSI Pharmacy. For the first pharmacy I started, I didn't get to choose our name, right? And so I always couldn't stand our name, to be honest with you, because it was Artex, and I was like, well, we're taking care of patients in more states, and it shouldn't be just limited. Well, I got to choose this one, and I usually tell this story because I'm not very creative usually, but this time I was like, all right, I know I want the words clinical in it, I want the word specialty. Specialty pharmacy is kind of the word of the day, and I've been thinking about it a few days. I woke up in the middle of the night, and I'm like, I got it. We're going to call it Clinical Specialty Infusions, and for short, CSI Pharmacy, and people will think about what? Crime scene investigation, right? I'm like, that way they won't forget. And so we went on to even get a logo with a thumbprint and a magnifying glass, like it's crime scene investigation. And it actually fits really well because there's a lot of investigating that goes into taking care of patients, particularly those with different forms of myositis. So it turned out to really fit in multiple ways. And inside that thumbprint it says, individualized therapies designed to be as unique as you, just like a thumbprint's unique to you. And it's something that I've become very passionate about, that we really should provide cookie-cutter therapy. We really need to go in and tailor regimens the best we can to give patients the best, as I said earlier, the best chance at a positive outcome. I'm also on a standards committee for the Immunoglobulin National Society, and we work on a national level to start set standards for the administration of immune globulin. Our company mainly infuses patients in the home, but but a lot of what I'll talk about would apply anywhere you're getting your IVIg. I came to be with the Myositis Association. I came to be with the Myositis Association a little bit differently. So again, a few years ago, we were, as a company, I realized we really needed some help on the patient advocacy side. Because, you know, I'm a pharmacist, and we had great clinical nurses, and patients needed help with insurance, though. And it really was not something, you know, that we're definitely experts at that time in getting it approved in the majority of cases, but we needed someone that could work one-on-one. And at that time, maybe in my mind, I was just thinking insurance, because honestly, I didn't know patient advocates encompass so much more than that. And there was a lady out there who I had formed a friendship with online, who runs some support groups, and her name is Michelle Vogel. And Michelle, raise your hand right here. So y'all can see kind of where this is going. We were looking for this patient advocate and started recruiting Michelle at a time in her life that she was looking for something else. And we came together a few years ago, and I'm like, Michelle, I want you to work on our advocacy program. You know, let's start with like good compassionate care, have to work at a good compassionate care program and help patients with insurance. She's like, okay, we'll do that. But first, I want you to meet this patient community. And I'm like, okay, great, who is it? You know, it's a myositis. I'm going to take you to Houston and introduce you to this kid group there. And I think you really will get a lot out of it. And while you're there, you can speak about IVIg. And I'm like, well, I've heard of myositis, so yeah, I'll go down there and I'll share what I know about IVIg, and maybe I'll give them a lot of good information. I met many of you there that I see in the audience right now at that first KIT meeting, some at the first KIT meeting. And I got there and I realized there's something special about the myositis community. For one thing, I learned a lot more than what I taught that day. And I left there going home saying, wow, there's a lot I have to learn. And so that started really this new passion in my life of working with patients with autoimmune disorders. We'll travel around the country and go to KIT groups and some of the other autoimmune rare diseases. And it's done so much for our company. It's made our company better. It's done so much for me individually. So I'm real honored to be speaking here with the Myositis Association today at the annual patient conference. Okay, so now that that's out of the way, let's get down to the meat. And we're going to talk about IVIg. So let's start out talking about what is IVIg. And so very basically, IV is what is intravenous, Ig is immune globulins. So it's immune globulins that are administered intravenously. This could just as well say SCIG, and that would be subcutaneous immune globulins. So it's immune globulins administered under the skin. So what are immune globulins? Well, it's simple, they're antibodies. They're antibodies, and we know, we heard Dr. Manning talk about this a little bit yesterday, about antibodies and autoantibodies. Well, antibodies are that component of our immune system that help us recognize and fight infection. And there's 5 types. So there's IgA, IgD, IgE, IgG, and IgM. And these each have different functions. And we're mainly going to talk about IgG. That's the primary component in IVIg, okay, which is really the workhorse of the immune system. So altogether there are currently 10 brands of IVIg. We'll talk a little bit about them. 3 brands of subcutaneous. I'm going to talk about those. We're going to talk about how they manufacture just a little bit, and they come from plasma pools. Again, the primary component is IgG. And this is an important point, the very last one, because we're going to talk about this quite a bit. The brands are considered to be, for the most part, equally efficacious. Okay? However, they have different formulations and therefore have different side effect profiles. So what one person may tolerate a particular brand and someone else not be able to tolerate it. However, the person that can tolerate brand A can tolerate brand B, but the other patient can't. So it's really, again, something that needs to be individualized. And we're going to talk about how you choose the best brand to give someone the best chance up front to respond well. So the manufacturing of Ig all starts with plasma donation. Okay, I met a gentleman last night. Let me see if I don't think he's in here. His name's John from Southwest Florida. I've donated 60 gallons of plasma. Now, I think it was actually a little bit more than that. 60 gallons of plasma. Well, what happens with that plasma once it's donated? Well, first you're pre-screened, okay, so there's a lot of safety checks that go into that. And you go in and you donate this plasma. About 55% of the total blood volume is plasma. Okay, and from that, most of that's water. So most of that 55% is water, only 7% of it is proteins. Well, it's these proteins we're really interested in when we're looking at plasma products, okay? Those proteins are further broken down into 38% immunoglobulins, okay? So that's what we're talking about. 54% of it, albumin, comes out of those proteins, and albumin is used to treat trauma in patients with massive blood loss. And then you have these factor products in this miscellaneous, well, only 1% of this factor products, and these are patients with hemophilia and body factors that help blood clot. But it's this IG that we're really talking about here today. And from here, the manufacturers will take this IG fraction out from these proteins, which came from the plasma, and they will, through a process of viral inactivation, stabilization, multiple manufacturing processes, it'll end up in a bottle ready to be infused, immunoglobulin solution, and that's what shows up to your home or to the infusion suite to be administered. So we said that IVIg is antibodies. Okay, so Ig, immunoglobulin, equals antibodies. This is a cartoon, and I don't know if you're going to be able to see it. I tried to make it as big as I could. But this cartoon was actually given to me by a patient whose spouse, the two of them together, work on making cartoons related to her rare disease, which is an autoimmune dysautonomia. And she receives IVIg, and so this is the cartoon they made, and her husband illustration. I just thought it was brilliant. But this is a bottle of an Ig solution hanging here. It's a 10% Ig solution. And inside you see these little Y characters, right? And the reason why it's a Y is because IgG, immunoglobulin G, which the primary component of these, the workhorse of the immune system, is shaped like a Y. And so you'll see all these little Y's in here that came from 1,000 to 10,000 different people in this plasma pool in the very beginning. And this guy up here, this green guy up here, says, I fought cancer in Memphis, how about you? And he's talking to his buddy, and he's like, well, I was flu in Phoenix. And I just really thought it was brilliant to demonstrate how you have these, this conglomerate of Ig from multiple sources and multiple patients. And this guy here is really wanted to be donated because he wanted to travel, so he's traveled a lot. And my favorite here is, have you seen Sandra? Bad Sushi Sandra. Where's she at? And she's on her way down the tube down here. She's out here yelling, you only live once. So anyway, I thought that was a great illustration to show you IgG comes from multiple people, and there's millions of specific antibodies in that solution that fight and recognize different pathogens. And that's what the function of the antibody is, right? To fight off harmful substances in the body. Dr. Mammon discussed this, and antibodies recognize antigens on the surface of pathogens and viruses and help you fight those. They facilitate the neutralization, destruction, and eventually the elimination of bacteria and viruses and all these pathogens. But what's important here? Important is that it can tell what's bad and what's good, right? Almost like a police officer needs to know, this is a bad guy, this is a good guy. And because they're interested in the bad guys. And with autoimmune disorders, like the immune-mediated inflammatory myopathies and myositis patients, those antibodies, there's some of those antibodies that are recognizing good as bad. And so we have these autoantibodies, specifically myositis. These are myositis-specific autoantibodies. A list of them here. Again, Dr. Andy discussed this. I borrowed this particular slide from our friends at Octapharma. They sent this to me, so I need to let you know that. But this is just showing a list of some of the autoantibodies that have been identified. But these autoantibodies that are being produced incorrectly label a healthy, normal part of the body as being harmful, and therefore mediates that immune response Part of what IgG does is activate this system called complement that results in lots of inflammation. So you get that inflammation in the muscle, damage to the muscle, all just because these antibodies are signaling wrong to the body saying, hey, attack this. So how does IG therapy work? Well, here's a simple way to think about it. IG therapy decreases the production of these antibodies, so these bad antibodies. So how does that work? So you're giving someone this load of antibodies from all around the country that aren't autoantibodies, that are made to fight the flu and other bacteria. And then it kind of works like a thermostat. So you get all those on board. A thermostat, you're measuring the heat, and the heat gets to a certain point, and the thermostat turns it off. And so that IG kind of works like a thermostat, and then it turns off the immune system. Now that's oversimplifying the process. There's lots of proposed mechanisms, including the activation of the autoantibodies, including increase of the elimination rate of those antibodies. But the end, when you give IVIg, you get more of these good antibodies and fewer of these bad antibodies that are causing damage. So I told you earlier that there's 10 grams of IVIg, okay? And 3 grams of subcutaneous. And I've got a list of them here that there's no way you're going to be able to read this, and I knew that you wouldn't. And I'll just go through them quickly because many of you are probably on one of these brands. But you've got Immune, Infusion, that's a subcutaneous product, Gamma, GammaGuard Liquid, GammaGuard SD, which is a powder form, GammaKed, GammaPlex, GammaXC, Zentra, which is a subcutaneous product, IQVIA, which is a subcutaneous product, Octagam, and Privigen. That's the list there. That's 9. There's only 9 IG products there. I'll list the 10th here in a moment. But if you'll notice one thing, this is the route that they're given. Some of these IV products can also be given sub-Q. And here's the manufacturers. And here's the indications. Well, what do we not see on the indication list? We do not see dermatomyositis or any form of myositis at all. And that's because it's an off-label use. Now, don't be too discouraged because there's enough evidence out there to know that, to tell us that it's effective, that insurance companies will cover it in the right circumstances. But it's an off-label use. Now, I wanted to point out that in July of 2017, last year, one of these manufacturers, Octapharma, who's here with us today, who manufacture Octagam, they were granted orphan drug status for the use of Octagam 10% in dermatomyositis. And I think it's important because the myositis community is a small community, right? It's an extremely rare disease. And to get these big manufacturers to devote time and resources and money is a big deal. And Octapharma has stepped up and become a great sponsor of the TMA. So it's just something I wanted to point out that, these guys are here. They're working in myositis. They're trying to get an indication, which we'll talk about, which can only benefit this community in so many different ways. Also, in August, so this just happened. I only listed 9 IV products, so the 10th one has just been approved, and it's Octapharma's new IVIg product, which is Panzyga. I'm real excited about this one. It's glycine stabilized, which is a little bit different, and looking forward to that becoming available here in the next couple of months. We always need more brands because there's supply issues right now. Many of you have been influenced by that. I've already talked to a lot of people who have had to go from one brand to another. And demand is always increasing, so the more products, the better. And this looks like it's going to be really a high-quality product. Octapharma also has a phase 3 trial going right now with ProDerm trial, which is looking at Octagam 10% in refractory dermatomyositis. And that study's been ongoing. And they're also now developing a sub-Q product and have a sub-Q study going. So the whole point of the talk is to be about individualizing therapy. So how can we do that? Well, we can do so by preventing adverse effects. IVIg has a reputation for not being tolerated very well. And there's things we can do to make that more tolerable, including selecting the right product or the product that should work the best in the beginning, making sure we do that hydration and pre-medications. So many of the side effects are due to dehydration and a fast infusion rate. Also, administering these pre-medications can help. And like I just mentioned, tapering up that rate slowly is very important. So it's something I definitely want to cover. We're going to talk about how we can treat those adverse effects if they do happen, if you are somebody that experiences them. And then finally, how do we customize future infusions? Okay, so how do we change things after you experience this so hopefully it won't happen again? So first let's start with product selection. So general statements on product differences here. As I mentioned earlier, IG manufacturers over the years have tweaked their formulations to improve the safety. Although the primary component of IVIg is IgG for all the products, this is what we're getting is a 5% or 10% solution. However, they differ in the amount of IgG monomers, dimer, and aggregates, the different amounts of these other antibodies, different types of stabilizers and additives and levels of impurities. And what that all results in is they have different side effect profiles. One person may tolerate one and not the other because of these different impurities or additives that are in one brand. And so here's my bold point here, is by appropriate product selection and utilization, we can reduce the rate of these adverse reactions. So how are we going to do that? So here is a chart that comes from Tom Slice at the IGNS. He's a couple of these slides I'll be sharing comes from Tom. But this lists the product up here, and I'm not going to go into any detail at all. But it tells us the characteristics of these different products. So you've got, shelf life, concentration, what stabilizers used, what's the sodium content, osmolality, pH, IgA content, and finally, what's the anti-A and B titers, which is what attacks red blood cells. So it tells us these different formulation characteristics, and we use it like this, okay? So if we have someone referred to us and we're working with a physician on choosing a product for a patient and they have cardiac impairment, there's certain things that are important to us. One's volume load, right? Because cardiac patients are fluid restricted, they can only handle so much volume. So we want to choose a product that's concentrated, a 10%, not a 5%. We want a low sodium product, and we want a product with the osmolality, which is kind of the simplest term I'll use is thickness of the solution. We want one that's closest to normal, because if you get something with a really high osmolality, it'll pull lots of fluid into the vascular system, which we do not want to see in cardiac impairment. Renal dysfunction, kind of similar. We worry about volume load, also sugar content, sodium content, again, osmolality. In patients who have anti-IgA antibodies or low IgA levels, we can choose a product with a low IgA content. This goes on for those at risk for strokes and thromboembolic risk. Patients with diabetes, we obviously would want something that didn't have sucrose as the stabilizer. And again, with geriatrics and neonates, certain characteristics can better fit those or are more likely to be tolerated by the patient with the fewest adverse reactions. So what's the dosing look like for IVIg and subcutaneous Ig and DM and I guess it would be better to say necrotizing myositis or PM these days. It's generally Ig dose is 2 grams per kilogram, which is a very high dose, okay, compared to, I mentioned earlier that these products were originally approved for primary immune deficiency, but they get a much lower dose, okay? They get a dose of about 0.4 grams per kilogram in a month's time. And so with autoimmune diseases it has to be much higher, and with DM and PM and necrotizing myopathy, it needs to be up there around 2 grams per kilogram. That's what's recognized. From then, it's been dosed once a month at first, and then kind of reporting the patient response. So it may be that you get yours every 2 weeks or every 3 weeks, maybe even longer than that in some cases. And then the subcutaneous dose, and like I said, subcutaneous is just now really growing out there for autoimmune disorders and emerging therapy. The dosing varies greatly right now. It's not well defined in the literature. In our experience, and the rheumatologists and neurologists that we work at in myositis, this is would be a good dose, or a dose that we commonly see, which is just 2 grams per kilogram. Again, but this time that's divided up into weekly doses or twice weekly doses. And so why do we dose it once every 4 weeks or 3 weeks? Why does that work out? So what this is serum concentrations of IgG in the blood, and this is time, okay? So you've got 1 week, 7 days, 14 days, 21 days, or 28 days. The gray here is IVIg. You notice when we administer IVIg, we get this huge spike immediately because it goes straight into the intravascular space. And then you see this kind of rapid elimination. It kind of tapers out. But by the point being, by the time you get to week 3, week 4, that IgG has been eliminated from your system. And so unfortunately, it's something we have to keep giving and replacing. So IVIg, you'll typically see it administered every 3 to 4 weeks. Both of these are sub-Q products. The IGHY is a particular type of sub-Q product, a brand called Hypotension that's a little bit different. But with the sub-Q products, you see this more frequent administration for one thing, but you see this level, this kind of constant level of IgG. And there could be some benefits to that, which we'll talk about. So how do we prevent adverse reactions? Again, it starts with product selection, and we want to make sure we pre-medicate with Tylenol and Benadryl. And then I'm going to highlight these, and I know most of you know this, but I have to hammer this home. The most important thing we can do is adequate hydration, drink plenty of fluids. In many cases, we're going to administer these fluids ourselves just to ensure the patient is well hydrated, because it's so important when it comes to patients tolerating their infusions. It needs to be a slow infusion rate. We need to determine what rate is right for you. Here's some of the common reactions. I'm not going to go into all these, we can say common reactions. Here's some of the reactions we can see with IVIg. And I'm not going to go into all of these. I'm going to go into the more severe ones just a little bit. And then I want to talk about the reactions that do occur more commonly. So first, serious reactions is we look at anaphylaxis. And there's a kind of a stigma out there that IVIg, a lot of patients are at risk for these anaphylactic reactions. Well, true anaphylactic reactions to IG therapy are really extremely rare, but that doesn't mean we don't need to prepare for them, right? And so if you're getting IVIg in a suite or the home, it's important that your nurse has an anaphylaxis kit nearby. We have orders from the physician on how we will handle anaphylaxis, just in the event that there is an anaphylactic reaction, in which you would see that your blood pressure would bottom out during administration, incredibly difficult breathing, and the infusion would need to be stopped and call emergency services and administer epinephrine. Now, in those 18 years that I've worked with IG, there's only really 2 cases I can think of right now that may have been anaphylaxis, and both of those are even questionable. We're not sure that's actually what was the case. But they did end up calling these emergency services, and that's over 18 years. Patients who are IgA deficient may be at higher risk, and even that's debatable. But what we can do in that group of patients, these are people who do not make the antibody, or very much of the antibody IgA. Well, what happens is, since they don't make much of it, their body recognizes that as being foreign, and they can have a higher risk of anaphylactic reactions to that. But we can do that by choosing a product that has low IgA levels, or going to subcutaneous. Aseptic meningitis. So this is the one most people have heard about, and anyone in here experienced aseptic meningitis? So we've got a couple, and fortunately, I have not experienced this myself, but what I've been told is it is extremely painful and debilitating. You get this severe headache after the infusion. It can last for 3 days. It's from the IG actually inducing inflammation in the spinal cord. The risk that it will go away, but again, it's extremely painful, so it often requires that patients receive pain treatment and what have you. However, there are risk factors for it. It's a high dose. Again, if you give it too quickly, most of the cases of aseptic meningitis we see is a situation where a patient was given the infusion way too fast, or they were dehydrated beforehand. We do not really see a whole lot of this, and I'm not going to say we don't see any, because there's some patients who just seem to experience aseptic meningitis. But you can really cut down if you hydrate aggressively, slow the infusion rate. Let's taper that up very slowly. Let's find out what rate you tolerate, and then if in future infusions, if we are seeing this problem, we can always switch brands. Sometimes that'll make a difference. And these patients are really ideal candidates for sub-Q IG. Immunoglobulins administered under the skin have very low risk for aseptic meningitis. Here's a real common one, headache during the infusion. All right, so this is not listed as a severe reaction, but it is a more common reaction. It may be due to those low levels of impurities in one product versus the other, or in IG in general. Now, here's the key here. If you back off and slow the infusion rate, usually this rapidly goes away. Okay, so the way we like to do this is when we start a patient, we're going to start with a very low infusion rate. We're going to ramp it up, and at any point, the patient, we're taking blood pressure, right? We're taking the vital signs. We're constantly assessing the patient. And anytime we start to hear a complaint of headache, or we start to see blood pressure changes, usually it's hypertension, blood pressure going up, we're going to stop that infusion until it resides. And then we're going to back down to the rate we were doing before this started. And from that point on, that will be that patient's max rate. So we may have had plans to eventually get up to a higher rate, but if just throwing something out there totally random, if 90 milliliters an hour is the previous rate where you were not having reactions, that's what we back down to. Pre-treatment with Tylenol and Benadryl help with this, and again, hydration. And for future infusions, it may be necessary to switch brands. Again, that is usually a good alternative if you just have headache after headache, or try a subcutaneous immunoglobulin. Flu-like symptoms are another one. These can be mild to moderate. These are the chills and fever, headache, what you would normally experience with the flu that occurs hours a day after the infusion is stopped. This is about administering slowly and make sure there's pre and post infusion hydration in that case if you've got someone who's not really hydrating well on their own. And we can also pre-treat with soluble here, or glucocorticoid, and that helps tremendously with these flu-like symptoms. And if we just keep having them, we can always switch to subcutaneous. And then I believe this is the final singular adverse reaction. I think we may have one more slide. Rash, I wanted to cover that because some patients really experience rash with IVIg. We think it's an allergic reaction to one of the components, so it's just like, talking to, or coming into contact with an allergen out in the forest and you have this rash from it. We think it's kind of similar in that maybe there's a component in that IVIg solution that you're reacting to allergically. And this can be treated with a single dose, typically, of antihistamine, or again, a glucocorticoid, which is something like soluble or prednisone, usually will make that rash reside. For future infusions, we can pre-medicate with an antihistamine, which a lot of times we'll do anyway, something like Benadryl, and we can always switch brands because it's likely a component to a specific brand or POV. If necessary, we can usually see less rashes or systemic allergic responses to subcutaneous IG. Other adverse effects that are serious, you got thromboembolism and acute renal failure. So every IG product, IVIg product, carries a risk for a black box warning that says patients will be at increased risk for thromboembolism and acute renal failure. Now, there's a lot of acute renal failure in the 70s before these IG products were tweaked more in their formulation, and about 80% of what we saw out there, the large majority, was in sucrose-containing IG, which is only one sucrose product on the market now that stabilizes sucrose, and that product is supposed to be phasing out of being available. It is Caribbean, is the one sucrose stabilized IG product. So again, patients who are at risk for these, there are certain things we'll do with brand selection. Obviously we'll make sure we're not using the sucrose-containing IG, and then we want something, as I mentioned earlier on the risk factors, we can choose certain products to help prevent these two serious adverse reactions. The other products which aren't sucrose-containing do have a risk for acute renal failure, and they all seem to have about an equal risk. Like one doesn't seem to be better than the other. And then finally, hemolytic anemia. Okay, so this is because all these donors have different blood types, right? And we're not really know who's coming from where or what blood type the patient's going to have. So there will be low levels of antibodies, and these are removed in the manufacturing process. There will be low levels, and the FDA does regulate what those levels have to be under a certain amount. But these antibodies in this IG solution maybe can attack your red blood cells because they're different than what they were for the donor. And we get anemia from that. It's pretty rare that we see severe anemia. Now, we do more frequently see what we call subclinical anemia, which means your hemoglobin and hematocrit are a little bit lower, but you're not really experiencing symptoms of anemia from that. But we can, in those cases, when we do see it, we can move to a brand with a low anti-ABO titer, and that's on that chart I shared earlier. You know, there's a level at the very bottom, and this was put together by Tom, and he's went in and done the research himself, talking directly to manufacturers, and some have lower levels than others, and so you'll see a ranking of high, moderate, low, very low, and so we'll help prevent that. Other things that can be done is we can separate the doses out. Okay, so if you're getting it over 2 days, once a month, we can put a day in between those, or we can move you to talk to your physician and work with you on possibly giving half that dose every 2 weeks. You know, so you get the same dose each month. And by giving a lower dose, you're not getting that huge load of IgG, which is, when that happens, you really see a breakdown of the red blood cells because there's just so much in the system there at once. So I did want to talk about subcutaneous immune globulins. Again, I think this is something that we're really going to see more of in the future. It's really emerging. Right now we have 3 products approved for subcutaneous use that are specifically subcutaneous, and that's Hizentra, Hypotension, which is a 10%, and is a little bit different in the way that it's administered, and then Infusion, which is a 20%. And then there are these 3 products here, GammaGuard, GammaNex, and GammaCAD, that may be administered either way, IV or sub-Q. Michelle got me this nice little slide changer, and I really love it, but I have been really, my fat fingers are just not made for this slide. But I'm thankful for it because I'm not over there having to do this. But if you'll look here with the subcutaneous immune globulins, here's, for example, Hizentra. It comes in a vial. It's drawn up into a 60cc syringe, put in a syringe pump, and then it's administered under the skin. But what's unique about this is patients can be taught to do this themselves. Okay, not all do. The great majority end up self-administering their sub-Q. And so you can imagine some benefits if you were not having to wait for a nurse to be scheduled, or if you were traveling or what have you. That's just one of the advantages. We'll talk about some other ones. This slide is, again, a chart of the products that are given subcutaneous and their product characteristics. So what's some of the possible advantages? I was just naming one of them. Well, first of all, subcutaneous weekly infusions keep that IgG level at a steady state, so it's more consistent. Okay, and that may play a role. Like, there's not really any studies out there that say, oh yeah, that's better, and perhaps having high level at some point may be beneficial. But I kind of view it as you need to maintain a certain level to adequately produce the response to the disease that you're looking for, and we get that to be more stable. People that have IVIg with autoimmune neuropathies or myopathies, a lot of times will complain of weakness about week 3 or week 4, and that's because that level's really fallen off. So in that situation, if you're one of those patients who start to see it becoming less effective, you can talk to your physician about possibly, instead of every 4 weeks, breaking that in half and doing it every 2 weeks, or administering it subcutaneous if we can get your insurance to cover that, which we've been successful in several cases with myositis patients. Another benefit, no pre-meds required. That's because the side effects are mainly localized, meaning right at the point where you put in these little subcutaneous needles, and it's so much easier than what you think it sounds like. These are not any complicated manipulations. You just literally put something in at a 90-degree angle. But there'll be localized reactions a lot there. But as far as those systemic side effects, so the Some of the ones I were mentioning earlier, the aseptic meningitis, the headaches, high blood pressure, are really a lot lower subcutaneous than what you see IV. Another benefit is that autonomy and independence I was speaking about. Right? So now, if you're traveling, well, you just take the product in your infusion pump with you, and you're on your way. So that's another. And then for someone who doesn't have venous access, right? So you can't ever get a vein. I'm sure a lot of y'all had that experience. Can't get a vein. Some people may have ports and other ways that their IG is administered because of that. But you don't need a vein if you're giving it subcutaneous. It's just going under the skin. So that's something that could be considered. Again, this is still early stages of this being used, in particular with something like myositis. But it is being used out there by some of the experts. That doesn't mean it's right for you, and obviously that's up to your physician to make that decision. But it's something I just wanted to make you aware of, that there are options, especially if somebody's, maybe you're not on IVIg right now because of the venous access issue. Maybe this would be something to go to your doctor and say, hey, how about the subcutaneous form? One more thing before I get to this, we're almost to the end here, but back on subcutaneous, I did mention there was 3 subcutaneous brands now, and 3 that can be given IV or subcutaneous. There is another one being developed by Octapharma right now. It's a 16.5% subcutaneous that's still in the developmental studies, and they're doing a subcutaneous study. So definitely go by their table and talk to them about that. Again, I would be excited to see another subcutaneous brand come to the market.
James,
yes?
Do you have to do site rotation on the subcutaneous?
Yes, you do site rotation, and your nurse will cover that with you. Roxanne in here? She's not in here, so she missed out. But come by our table and talk to Roxanne. She is treated, or one of the other specialty pharmacies may have someone there. She's a nurse educator that is certified in IG administration, and she teaches a lot of subcutaneous patients, and she can explain exactly how that works. So what's some common complaints, or maybe not common, but complaints we've heard with home infusion, and this is what I'm calling unacceptable practices. Now, a lot of the folks here, you're probably not going to see these things with, but there are home infusion providers out there, and what makes it really hard is when we go work with a physician for the first time, and they're like, oh, you're one of those companies. And we're like, yeah, but we promise you we don't do these things. And these are things like, we had sent a bill because it wasn't covered by the insurance. I just feel very strongly that we are the experts in how IVIg is covered, and it's so different from insurance to insurance. I just feel very strongly that if we're verifying those benefits with you and doing predeterminations, and we say you're covered, then you should be covered. And in our place, when you're set up and we say it's covered, it's because we've made darn sure the insurance is covering that product. And if they don't, we're taking that fight with them, not with you. You know, we're going to go directly to the insurance and say, wait a minute, you're wrong here, this needs to be covered. That may be a process, but we'll get it paid. What we won't do is surprise you with a $8,000 bill out of nowhere. But that's something that shouldn't occur. So the Medicare doesn't cover my IVIg unless I go to an infusion suite. Well, that's kind of true in a way. Certain type of Medicare only covers IVIg in a doctor's office or hospital. But if you have Medicare Part D, it provides great coverage in the home. So if you want to get your infusions in the home, but all you have is Medicare, look at it at Part D plan. A lot of times they're very affordable. They'll help with your other medications as well. But there's great coverage there. All right, and most of these are related to nurses being in a hurry or a company really looking at their profits over patients. Nurse starts infusion and leaves, comes back at the end. Nurse needs to be there. What if the time that you're gone is when you have a serious reaction? We'll only infuse one of the products, but not the saline and hydration. That's just silly. Nurse will stay for a maximum of 4 hours because the insurance will only cover that many. That's one that really bothers me, right? So my saying is we're going to do it right or we're not going to do it at all. If we feel like it's going to take extra time, we're going to get hours authorized to do that. But if we don't get the authorization from the insurance, that patient's not treated any differently from anybody else. The idea is, what rate do you tolerate it at? what's going to work best for you as an individual. So insurance should not be dictating clinical care. These are some of the more severe ones.
4 hours, is that also in a clinic? Do they restrict the hours?
You know, that's a good question. I've heard these complaints about home. That's probably because I'm coming from the home infusion perspective when I'm talking to people, and they're saying, yeah, but the last time I got in the home, this happened. So that's a great question. I'm not sure if they'll do that in the infusion suites. Hopefully not. And then just a few more things here. Nurses training patients how to infuse through their cord, telling them if you have a reaction, this is what you need to do, I'm out of here. Tells the patients they have to infuse it fast. You know, I've got someone else I have to see today. We have to do this fast. That's is not right. You know, that's all I can say is there's no reason why you need to suffer for 3 days because, you know, we're looking at making more profits and getting another patient infused. Again, we've talked about that fast infusion. And then finally, lack of follow-up by the nursing home infusion company regarding reactions. So your care does not stop when your infusion stops. There needs to be follow-up calls after that. There needs to be not just about your IG, certainly about your IG and your reactions, but how are you doing? Is your disease responding? Are you experiencing weakness? Going over your labs. So one thing we'll do in the pharmacy, and you may not necessarily hear from us if things are going well, but looking at the labs, looking at your CK levels, are those dropping the way we want? We're sending those to your physician. We're looking at renal function to see if the kidneys are tolerating everything okay. We're looking at your hemoglobin and hematocrit, about the anemia. Multiple things need to be followed up after the infusion. So that'll bring us to the end of the talk, and I really kind of rushed to the end because I felt like we were running out of time. So I kind of hurried up there. But we'll do some questions and answers if you guys have any. If you want to reach me at some other time, you can always email me. That's my email address. I made sure that was there. And then you can always call the office and ask for a pharmacist as well. Okay, so hands up for questions. How are we doing on time first?
You've got 5.
5 minutes?
5 minutes. Okay, so that worked out great. Yeah. All right, what we got here, Mike?
My nurse and the doctor mentioned something about, well, this is for a lifetime.
Yeah.
Is this for a lifetime in your opinion?
So that's a great question. So the question was, the doctor and nurses said, this IVIg or this immune globulin therapy is going to be for a lifetime. Well, the answer to that is, yeah, maybe. You know, probably. Because, again, as I showed you earlier, it only stays in your system. It's only a short-term fix, okay? So it only stays in your system for 3 to 4 weeks after it's administered. Well, during that 3 to 4 weeks, when you have the level where it needs to be, it's keeping those autoantibodies low, and so they're not damaging your body, okay? And so so we have to keep those levels high. Now, something may be developed later that would end that, and let's hope that there is. But for now, I'd say, yeah, if you're responding well to IVIg, you're probably going to keep getting it. And so that is an important question. It's not something. Now, there are some autoimmune rare diseases that get it for shorter periods of time, and then if they have a relapse, they're put back on it. But
It seems to me like the subcutaneous then would be much more convenient if you're going to be doing it for the rest of your life. Do you think that's just as effective as subcutaneous?
we believe it, you know, and this is not just speaking on my behalf, but on the pharmacists I've spoken to in the industry, the physicians I've spoken to, the Immune Globulin National Society. Although there are some studies that demonstrate equivalency between IVIg and myositis, they're just very small studies. Yeah, we believe it's equally efficacious. It's all about getting a serum level of IgG. So if you can get it, you know, that's kind of the thought out there. Hopefully, I think we're going to see more of it. I don't know if that's going to take 2 years, 3 years, or 7 years, but I do think that there will be a day. And what Aquapharm is doing with this Q2Quick, which is their new sub-Q, that may get us there even sooner if they really get that done. But I'd like to see it available for more patients, you know, for more people to be able to go the subcutaneous route. We have gotten it approved for myositis patients. A lot of times we'll have to show why they can't take IVIg or show that if they do take IVIg, it's incredibly intolerable. Yes, ma'am.
Well, the one thing I've heard about the sub-Q, because I'm kind of interested between myself, is that you really don't have a lot of subcutaneous tissue.
Right.
Many people get very, very sore that because of the, it's whatever IVIg is made of? Because also IVIg sometimes will cause an inflamed vein all the way up
Right.
where the vein is, even if it's a good vein. And what's the cause of those?
Right, so that's a great question, and I'm glad you've asked it, because one thing I realized going through these slides is I really painted this picture that Subcutaneous is just perfect, right? Well, it's not, and so that's probably something I need to find a way to address, because that's really a great question. Not everybody is able to administer subcutaneous IG because of their fatty components and the way that their abdomen, usually it's in the abdomen, but it can be in the thighs as well, so there are other places to look at. Or they do have reactions, and they can't quite, and I don't know a lot about evaluating, our nurses do more of that than I do, and certainly that's something I've been Roxanne can answer. It's like, how can you tell who's a good pitcher? I mean, who would do well, who wouldn't? But that is true. Going back to the vein irritation with IVIg, yeah, that's something that potentially can occur too. With lots of different IV solutions that can occur with, IG being one of those. But I think it probably has to do with it being really osmolar, it's thick.
There are spots. So, I mean, with the primary immune deficient community, which is started with, they started with little kids. So, little kids started using it, 4 and 5-year-olds would do it in their thighs, so they didn't have a lot of fatty tissue. But I know patients who are doing it even in like the back of their thigh. There's different areas that you can find, or in the back, right in this area, there's different areas, there's spots, so your nurse will work with you to find different spots to rotate, to find that best spot for you to work with. So there are different places to find that will work with you, but you will get, there'll be, a lump, and then you have to find areas that will dissolve, that will go down. But there are areas that will be more sore and other areas that aren't as sore.
Yeah, this is what this was, I don't know what they were saying.
But I
They love the idea of it, it's just that they had some difficulty with pain and soreness, and then, you go one place to another place, this isn't quite ready for it. And it's just, like you say, finding.
I put you in touch with our head of our nursing, actually
Gets it,
does
right.
subcutaneous. So I can put you in touch with
I
her,
go
so
that
you
route.
can talk to her personally about her own experiences. Okay?
Those are great points, and I mentioned earlier, that developing an advocacy program is a big deal. But that's one thing that's really helped Michelle answer that question is, Michelle's done a good job. She's been involved for so long that she really thinks about things from the patient's perspective in ways that I haven't learned how to do yet. And so we'll include her on clinical talks all the time with the nurses and pharmacists, and she'll say, yeah, but Mr. Jones, has this situation, or we really need to get him some PT in there, and things like that. So great help, for sure. Yep, Bill.
And I think another advantage of that is for a person whose veins are very deep, who's a hard stick and comes away totally bruised, just to donate blood.
So one thing that was pointed out there is that, and I didn't mention her either, our director of nursing, Brittany, who's not here with us, she was here last year, she's actually an autoimmune patient herself with, and she don't mind me sharing this, but with myasthenia gravis. And so IVIg is one of the things you use to treat that, or immunoglobulin therapy. Well, she's now approved for subcutaneous and administers it herself. So it really helps her when she's educating, patients. Let me show you what happens with me. And she'll post them on her Facebook page sometimes. I'm getting my infusion, which I think is great. It's not for everybody, and immunity is a good thing, but she really gets out there and says, look how well this works for me.
So, is there an issue if you're on a blood thinner?
No, I can't think of an issue right now, blood thinners and subcutaneous administration.
Does it cause any extra bruising?
You could see extra bruising, I can see where that may be something that would occur. That makes sense. It certainly makes sense from that logic, but I haven't heard of any direct contraindications of that. Anyone else? How we doing on time? Time's up. We got 0. We got one more question. One more here.
I've been part of the SCIG for almost a year, and talk about patient advocacy and health, and my nurse is a Louisville, so it's been
Thank you,
great.
Martha. I appreciate that. We had time for the advertising. I tell you what, just come up and see me if you want to after the talk.
I was just going to say, what's my farmer?
Yeah, I love you, Dr. Farmer.
Do you
Everybody.
guys have any questions? Stop by the table or
Yeah.
just come out?
Hooray for the group TMA. It's the Myositis Association, helping patients become peers now for the past 25 years. So if you have been diagnosed, here's an organization to unite us. 8,000 members they can boast. For that real strange word that no one's heard, it's myositis. There's an annual patient conference which is just second to none, where you'll learn a lot and network, and you'll also have some fun. And their website is updated with a lot of current news, with lots of info and resources, and much more that you can use, like info TMA compiles, and like lists of clinical trials, and lists of research too. You can review, cause it's all there for you. So hooray for the group TMA. It's the Myositis Association, helping patients become peers now for the past 25 years. So if you have been diagnosed, here's an organization to unite us. A quarter century they can boast. They've been the group that's got the scoop on myositis.